40-year-old man presents with symptoms of dysphagia that been present for many months, okay? His investigation demonstrates lack of relaxation of the lower esophageal sphincter during swallowing. What is the most likely diagnosis? So you know that is basically giving you the diagnosis or definition of one of the differential diagnosis of dysphagia, at which there is lack of relaxation of the lower esophageal sphincter. But here it mandates us to memorize the differential diagnosis of dysphagia. So if you're having a patient presented to you by dysphagia, which is difficulty in the swallowing, okay? So there might be multiple reasons for that. So before we crack into this, let me draw you to the esophagus. There is a myth or like mononymic in medicine in general that tells you that if you're having any tube and this tube is at risk of obstruction, so the obstruction might be something from outside or something from the wall or something from inside, okay? Or it might be the nerves that control this, so it might be neurological, okay? So here is the case is the same. If this is the esophagus, so the case is exactly the same. So from outside, you might be having two things. Either a lymph node enlargement, okay, or any mass that compress on the wall of the esophagus, leading to chronic dysphagia. From the wall itself, you might be cancer, okay, in the wall itself. It might be a structure by something called Skatsky ring, okay? Skatsky ring. It might be motility disorder from the wall. And these motility disorder include, number one is diffuse esophageal spasm. Number two is achalasia. Okay. Number three is nutcracker syndrome. This is from the wall. Something from inside, it might be a mass inside as well. It might be a tumor, okay, or either a benign mass or malignant tumor. This is from inside. Neurological, it might be having those patients presented with a stroke, and those patients who are having myasthenia gravis, okay, or even Guillain-Barré syndrome at a later date, or patient on certain medication that increase the risk of dysphagia. So in achalasia, this is what I want to point out here. So in achalasia, you'll be having a patient presented to you by retrosternal chest pain. Number two, difficulty in swallowing. Number three, sometimes aspiration. Number four, cough. Number five, halitosis. Okay. Number six is feeling of heaviness, always after eating. And it will be a long-term condition, and it will be in young men, not in old, because in old might be cancer. Most importantly, it starts for problem in swallowing for both fluids and solids. Because if you look at it, so the end of the esophagus will be exactly like this. Very smooth end, okay? So, and the sphincter here is very tight, so it wouldn't let anything pass, neither fluid, neither solids as well. So how would you diagnose a patient with achalasia? So the first line investigation is endoscopy. For any patient, doesn't matter the age, and you might need to take a biopsy as well if you found any mass or anything suspicious like an ulcer. Number two, you need to do manometric studies and pH. Manometric studies and pH. Plus pH. And this will tell you about the achalasia or any of the motility disorder. Okay? You also need to do the routine bloods like FBC, UNE, and so on. And the treatment for achalasia, sometimes we do two things, either pneumatic dilatation or botox injection. Okay, so that's it for today. And that was the differential diagnosis of dysphagia. Thank you.